I'm Dr. Alberto, clinical psychologist and director at Clement Mind. What you're about to see is a discussion with one of our current partners about how our collaboration has improved their services. Many care companies, such as yours, may already have psychology departments, but clinical psychologist roles often remain unfilled or rely on locums. Clement integrates directly into your existing clinical team as an extension of your department, not as a separate company. We have capacity to expand by one care provider and are looking to find our next partnership. So secure a meeting with me and see how we might achieve these results together. Thank you for watching.
David, you've been involved with Marbrook since it opened.
Yep.
Tell us why you joined and what the project has evolved into over the years.
So I started at Marbrook before we even opened. So my first go around the building, it was essentially still a building site. And it was an opportunity to be involved with a project from the beginning. Marbrook specialises in neurological rehabilitation, but I like to think that we're able to provide services to a range of individuals with different conditions. So from that perspective, we are supporting people with both cognitive impairments, but then also those who are not necessarily having a cognitive impairment, but needing support for their physical needs, their adjustment, their emotional side, as they come to terms with experiencing what are quite significant life-changing events. I think when working with Clement, what it's allowed us to do is have a greater level of flexibility. It's allowed us to be probably a little bit more dynamic in terms of our service provision. Because we're supporting people with different levels of need, what that's been able to do, working with Clement, is you can have individuals who need this type of support or need this, and Clement's been able to react to that and been a lot more of a dynamic partner, as opposed to if you have a locum, that can be, you're very much beholden to their specialism, same as if you recruit an individual, if that's their specialism, it's a bit difficult to support a breadth. Whereas when you're working with a company or a different organisation, they can have different members of the team, different people, and we can adjust our input. And I think for me, the challenge is always, how do we keep moving forward? So, as you say, our service provision and how we've been able to work with our NHS partners has increased. So we've had a greater number of beds, we can support more people. That comes with its challenges of recruiting and getting staff in, but it's how do we keep pushing forward? How do we make sure that we don't stay static? I like to think what we do is provide a really good service, but how do we continue to do that? How do we stay up to date? How do we always meet those challenges and not say, we're doing really well and sort of sit back and rest.
You talk about the importance of not stagnating as a service. How has Clement, or how does Clement contribute to that expansion?
I think it's been really interesting the working collaboratively, because my background, I'm a physiotherapist, so I have an understanding of the role and the benefits of psychology, but actually then working closely with the team has really allowed me to understand greater number of areas where we can be supporting individuals, how that's allowed us to say, actually, there were areas where we maybe weren't doing as much as we could do, and we've expanded that. There's been lots of input from Clement as a partner to say, well, what about this? How could we improve this? It's not just been a case of, oh, great, Clement, you come, people come in, do the work and go. There's been an active partner in that.
Emma, you joined Marbrook within the first year of opening. What was it like in the beginning?
The complexity of our caseload, I think, was a lot different then than it is now. I feel like it is much more complex, both socially, physically, psychologically. Age profile of our residents, particularly on Eden, which is the rehab unit, I think is a lot younger now than it used to be. There's a lot of, with medical advances, there's now a lot of people surviving brain injuries, spinal injuries, strokes that they previously wouldn't have survived in the past. So there's now a lot younger population coming through with the long-term then consequences of ABIs, strokes, brain injuries.
You've talked about as the service developed, you were able to offer a more specialised service. Thinking back to those early days, what was it like working with this population without the input of psychology?
Anyone who works in any kind of a healthcare professional, no matter what your role is, you are inevitably having to support and coach people through what is a really difficult time in their life. The difference is whether you have the skills or not to do that, and certainly I had clients in a caseload where I often could provide some support and some emotional support or psychological support, but that's just not my skill set. There's times when I came out of meetings or therapy sessions where I just felt like I did my best, but I just wasn't enough to give that person the emotional support that they needed at that time.
The choice was made to employ Clement to provide that formal psychology input. What difference have you noticed in working with the residents since Clement's been involved?
The service has grown a lot, not just the psychology service as well, but I feel like the entire therapy team has grown and developed and upskilled in ways that I don't even think that I was really aware that I needed upskilling in. I think there's a lot to be said for having the right support and the right team around to give the level of emotional and psychological support that I just can't give as a physio. There's only having Clement to come in and take on that burden and manage that then really well. It made certainly at least my professional life easier, less stressful. I think it's made the quality of the therapy we provide here a lot better, a lot more cohesive.
What has it been like introducing psychology into that MDT that was already well established?
I think any kind of a change or a mix-up is a positive thing for a team because it's going to bring some new perspectives, some new ideas, and I think Clement certainly have definitely done that. There have been clients that we've had that I feel like if they weren't here, as if Clement wasn't here, I don't think that they would be leaving as cognitively able as they maybe are leaving at, or with a level of emotional support that they've needed or wanted. Like I said earlier, the complexity of the caseload that we have been getting over the years has just been increasing for lots of different reasons. I think part of the reason why we've been able to kind of do so well in those areas is because we've then had the right psychological support to give to these people.
Whenever we receive a new resident that comes here, on top of the brain injury that they are suffering and the major life change they're suffering, they already had a previous history. There are some factors that might predispose the person to have a mental health problem. We will assess using specific tools that allow us to get more information on those areas of concern. With that information, we then do the case formulation and we develop an intervention suited for the problems this person might have. During all this time, we always take part in regular supervision just to make sure that our practice is being up to a standard. And if anything needs changing, then we will adjust. Perhaps it's working for a person and suddenly it's not. A lot of things can happen during this long rehab process. And at the end of their period in here, closer to discharge, then we will gather all this information and we will create reports to explain the information we have gathered and all that we have done with them. And if there's any referral necessary, then we will also gather information for that. We have different kinds of interventions based on the person's needs, right? Some interventions we call high intensity, which would be when you see the resident in a more intense manner, more frequent, and then we also have some interventions that are low intensity. This might include, for example, group therapies or already predetermined programs that we can put into place, but they might not require that specificity to the person. In terms of high intensity therapy, we could, for example, have interventions more directed to mood, which when we will do talking therapy with the person, and maybe for cognition we would do cognitive rehabilitation tailored to the areas of impairment we have found in the person in particular. When talking about behavior, we might put into place positive behavior support plans, which are interventions or plans to intervene as a whole team in the behavior of this person and how to manage this behavior. A good way to track that our interventions are being effective and also that we are basically pushing the right buttons would be to assess, treat for a period of time that's enough, and then if possible reassess to see if there have been any changes in the person. For mood we would do exactly the same. We will pass some tests at the beginning of the intervention, and then we will progressively pass these tests again to see if actually our interventions are being effective, if there might be any factors that we haven't taken into account, then we have to adjust this intervention. So it's not only about the brain injury or the traumatic brain injury, it's about who this person is and how to assess in a holistic way so that we can bear in mind all these things in order to treat the person actually in a person-centered way.
So, do you want to be the next care provider to boost your income by 75%?